My presentation is on the human and financial costs of fatal and non-fatal firearm injury in the United States, a systematic review. Okay. So the United States has the highest firearm injury and death rates of 23 high-income countries. Nearly 80% of all firearm-related deaths that occur in these 23 countries happen in the United States. Firearm-related violence claims the lives of approximately 32,000 people and results in injuries to over 67,000 people yearly in the United States. For every death, there are 5 survivors who will need intensive inpatient and outpatient medical treatment. While death is a tragic loss, survival of firearm-related injuries can also be devastating. The direct and indirect consequences of injuries represent only a small part of the negative effect. They potentiate both mental and physical health complications among victims, perpetrators, families, and larger community. Homicide and firearm-related injuries cost the American people an astounding $51 billion per year in actual healthcare costs and lost productivity. The dollar amount does not include the tremendous costs associated with the legal system to manage violence perpetrators. Firearm research has been grossly underfunded since 1996, when Representative Jay Dickey sponsored a bill to amend federal firearm research spending. The Omnibus Consolidated Appropriations Act of 1997 stipulated that the CDC could not use federal funds to support gun control. As a result, the $2.6 million that funded firearm injury research in 1995 was reallocated to traumatic brain injury research. While this was not an official ban, the amendment and subsequent funding reallocation have functioned as a moratorium on firearms research. President Donald Trump signed Congress's omnibus spending bill in March 2018 with the provision for the CDC to conduct firearm violence research. The provision does not repeal the Dickey Amendment, nor does it provide funds for new research. Current research on firearms is mostly conducted through analyses of databases that tabulate firearm-related injury, such as the National Trauma Data Bank, the National Violent Death Reporting System, and state and facility-based databases. The Dickey Amendment and the resulting dearth of firearms research exemplifies predominant structural violence within the field of this study. Structural violence is an invisible yet pervasive form of indirect violence wielded by the prevailing system to maintain power. It is latent and resides within the constructed social system so that the source of the violence is obscured and its victims remain faceless. The perpetrator mechanism victim pattern is obvious and intentional in direct violence. Both the perpetrator and the victim know that violence is being committed. The victim's death is achieved through direct force, an unacceptable criminal act punishable by the justice system. The lack of recognizable actors and victims of structural violence is what makes recognition and causality difficult to prove, but does not lessen its effect of subjugation and disparity. Whereas direct violence is identifiable, intentional, and personal, structural violence is invisible, independent of intention, and impersonal. The victim's death occurs through deprivation, a normalized consequence of disparity. Firearm violence is the visible manifestation of structural violence. Examining the patterns, populations, and trends of firearm-related injury and death with the structural violence lens is to make the invisible visible. The aim of this systematic review is to synthesize the prevailing scientific literature regarding the financial and human costs of fatal and non-fatal firearm injury in the United States. A traditional clinical model review of the data typically focuses on modifying the behavior of the individual. This review is a systems-level review of the data with the intention of systems-level interventions. Using a structural violence framework for analysis, 8 recurrent themes were identified in the 19 research studies. This review starts with an explanation of the methods. Following will be a presentation of the findings and implications for future research, practice, and policy. The Prisma figure illustrates the literature search process. I screened 347 references, identified 67 potential articles, and ultimately included 19 relevant studies. The full texts were reviewed, analyzed, and synthesized. 8 themes were identified during rigorous analysis. The resulting themes include racial categorization as a social determinant, pediatric population, the impact of firearms and femicide, financial burden to society, social environmental influence on firearm victimization, the significance of time to firearm-related risk, suicide, and unintentional injury. And for the sake of the time, I'm going to speak about race, the impact of firearms and femicide, and the financial burden. 15 studies have race as a distinct variable in their data, thus making it the most analyzed variable in all included articles. Race was reported differently across research studies. All studies had Black, African American, or non-Hispanic Black as a racial demographic. However, racial categorization is either dichotomized or multiracial in its organization in all of the studies. The Martin study has only Black and white racial categories, while the Moore study has racial demographics divided into Black and non-Black categories. The Safavi study has only white or African American racial categories, but only 62% of the firearm injured in the study had their race reported, making 38% unknown race. Both the Weeb and Russo studies split the racial categories into Black, white, and other. Other studies included Hispanic, Latino, Asian, other, and unknown as racial groupings. The Fowler study had the greatest number of racial categories. Racial demographics were Black, white, Hispanic, American Indian or Alaska Native, Asian and Pacific Islander, and other. African American or Black adults and children were the largest victims of firearm-related assault, homicide, hospitalizations, and deaths. One study provided the racial demographics of all firearm-related victims, with Blacks as the largest victim group, yet did not provide the racial demographics for the various types of firearm-related injury, such as unintentional injury, assault, and suicide. Researchers from 2 studies found that African American males comprised between 95 to 100% of all firearm-related assault recidivist patients, or patients who were shot on more than one occasion. Recidivism was only presented in the findings regarding assault, the firearm-related violence statistically more prevalent in African American males, and not in findings related to firearm-related unintentional injury and suicide attempts, the firearm-related violence statistically more prevalent in the white or non-Black population. White or Caucasian adults and children were the largest number of victims of firearm-related suicide and unintentional injury. The non-Black category was highest in firearm-related suicides and unintentional injuries in the Moore study, thus consolidating whites and all other people that are either not Black and/or their race is unknown. Insurance data stratified by race reveals similarities and differences. Both Blacks and non-Blacks were equally likely to be uninsured or Medicare recipients. However, Blacks had higher rates of Medicaid coverage and less commercial insurance coverage than non-Blacks. Insurance data corroborates numerous studies that place the majority of firearm-related assaults in communities below the annual median U.S. household income. The concept of Blackness is central to the research studies. Public health researcher Chandra Ford asserts that the increase in health disparities literature, while critical to improved and more nuanced research, is still restrained in its explanation of racially driven inequities because of innate limitations within prevailing study designs and statistical methods. Often, race as a significant and explanatory variable is assumed, and documented differences may be used as evidence of genetic or behavioral differences by race. This may occur even if genetic characteristics were not examined in the study, conflating the use of race as proxy with the use of race as cause in research. The proxy of race indicates that a group is vulnerable to structural violence. Research that conflates proxy and cause minimizes the possibility for systemic change. 3 articles assessed firearm-related injury in women and girls. Women are mentioned in all studies where the gender demographics are reported, but these studies have findings that relate specifically to women and girls. 83% of female firearm injuries were assault-related. Likewise, females had a mean length of hospital stay greater than 5 days due to the severity of their injuries. Female victims of firearm-related murder are 44% in one study. However, disaggregation of this statistic reveals a gruesome finding. Intimate partners committed 59% of these murders, acquaintances committed 16%, and strangers committed 18%. Thus, women are more likely to be killed by an intimate partner than by a stranger. While any type of violence has the potential to be lethal, firearm-assisted assault is the violence most linked to homicide. Researchers in one study discussed the proximity to home as a factor in firearm-related assault. Home was the location of 73% of these deaths, and only 27% occurred in a public location. Consequently, a woman's odds of a lethal firearm-related assault were 3.8 times higher at home than in public. 8 studies assessed the economic burden of firearm-related injury at both the state and national level. However, all articles reported substantial differences in insurance status of their patients. Nearly 80% of the patients in one study were covered by Medicaid, while the highest percentage in another study was uninsured patients at 65%. The Alleretti study, a national study, reported the pediatric emergency department population as 46% Medicaid coverage and 22% uninsured. Leventhal's analysis, also a national study, reviewed the insurance status of the pediatric firearm-related hospitalizations. Nearly 50% of the patients were Medicaid insured, over 25% had private health insurance, and over 17% were uninsured. Their analysis of insurance status extended to the type of firearm-related injury, revealing that private health insurance paid for nearly 50% of the firearm-related suicide hospitalizations, while Medicaid paid for approximately 25%. While all 7 studies present the financial costs associated with firearm injury, 2 of the studies discuss hospital reimbursement. Firearm-related treatment billed to patients totaled nearly $142 million, yet nearly $31 million was collected from patients and the insurance companies, leaving the hospital with over $111 million in unreimbursed expenses. Total inpatient costs in the Livingston study were $115 million, and 75% of these expenses were not reimbursed. The remaining 5 studies report the associated costs as the total sum in relation to the study's time frame. When you examine these articles through a structural violence lens, it illuminates that these incidences of violence have more in common than is widely believed. While analysis of demographic variables is sometimes informative, identifying socially constructed mechanisms that may influence disparate health outcomes is most needed for interventions targeted towards the structural disadvantages. Embedded within acts of direct violence is the more insidious but equally destructive force of structural violence. The criminal justice system was and remains the primary strategy to manage interpersonal violence. The perception persists that criminalizing violence is both preventive through deterrence and curative through punishment. This reactionary approach to violence prevails despite the lack of evidence demonstrating actual crime reduction or deterrence. Likewise, the reactionary approach relegates direct violence as a singular incident, preventing a more comprehensive primary approach to violence. Violent behavior is then shifted to individual moral and spiritual inadequacy, absent work ethic, and/or a lack of personal investment in education while ignoring the social determinants. Structural violence places separate acts of violence in the context of social determinants, therefore making it a public health problem. A shift from treating interpersonal violence strictly as a criminal issue is greatly needed. This is the current treatment model. The community is currently mostly responsible for violence prevention, while the most energy and resources are at the tertiary level, the domain of the criminal justice and healthcare professionals. They are separate efforts. A public health primary prevention approach to violence could potentially reduce the daunting solitary work of the criminal justice system. The public health model would focus on the primary and secondary stages of prevention and collaborate with the criminal justice system in the tertiary stages of violence prevention. Shifting to prevention focuses the discussion and its resulting interventions on the central issue. Firearm violence is preventable. The disadvantage to this shift is that firearm violence prevention does not easily fit into prevailing models of analysis and evaluation. Firearm violence prevention initiatives are multi-leveled, comprehensive, and policy-driven. Likewise, there is an intense push for immediate political interventions rather than evidence-based interventions and ongoing evaluation. Implications for future research include targeted interventions to reduce firearm-related violence through prevention. Thank you.